For patients with CNS involvement, we often know less about which drugs are active and which drugs are highly active, and this is something that we really need to solve when we think about clinical trial enrollment and clinical trial prospective data to understand what we can expect out of current novel therapeutics when specifically thinking about CNS response. Fortunately, over time, I think we've come to understand that while we talk a lot about the blood-brain barrier, the blood-tumor barrier probably is more permeable. So we've seen a series of data come out in the past 6 months suggesting that agents we don't always think of as likely CNS active, having CNS activity potentially comparable to that seen systemically. It gives a lot of hope for our patients that we can expect some benefit from their systemic therapy, even in those not felt to be highly active. I think another substantial unmet need is understanding resistance in the CNS to current therapeutic modalities. And this is also quite challenging to study, and therefore our understanding of it has lagged behind our understanding of systemic resistance to targeted therapeutic modalities. So in progression, say in the liver or the lung, systemic progression, you can get a biopsy, you can do genomic profiling, you can do plasma profiling of ctDNA and get useful results, potentially actionable results when thinking about guiding subsequent lines of therapy. In the CNS, we can't do a CNS biopsy. Plasma ctDNA is unlikely to detect the genomics of the CNS, and therefore we don't yet know what those look like. Emerging technologies looking at CSF-based DNA profiling may help us to answer this in a slightly less invasive fashion. But these are challenging studies to do, and I think more time is needed to fully understand the clinical utility. I think this has become, again, heightened by the expansion of complexity of perioperative treatment. It used to be if a patient had early stage or locally advanced disease, they could go to surgery and come see medical oncology post-op to proceed with decisions about adjuvant therapy. So it's a very simple treatment pathway that most patients were following. Now with the availability of neoadjuvant as well as perioperative and adjuvant regimen and the need for biomarker testing in that perioperative and preoperative setting, involvement of all modalities early has been increasingly critical. I think so the multidisciplinary team is very important to help guide that decision making. It means you need not just a surgeon, but a medical oncologist and often a radiation oncologist as well involved right from the beginning. So certainly we have our own multidisciplinary teams where we meet and discuss our cases regularly, but it is important as you think moving outside of academic centers, how can we facilitate effective multidisciplinary discussion early, even in a community setting where it's not as easy to potentially meet all together regularly.